Good afternoon, everyone. We'll get started. I believe there'll be other people who join us as they wrap up their clinical activity for the morning. But thanks for joining us today. We are happy to present Dr. Naassan, who will be talking to us about managing hematological conditions. I'm Shannon Burke. I'm the manager of the Regional Cancer Program for the Central East Region, Cancer Screening and Prevention, and the Indigenous Cancer Program. I'd like to ask Caitlin Loudon to give a wave to the group. She's our engagement lead for primary care for the Central East region. And we have Dr. Avnish Mehta is our primary care physician lead. And he'll be joining on the call eventually at some point anyway, but coming to listen to Dr. Naassan's great presentation. So Dr. Anthony Naassan is a hematologist. He's actually a section chief for hematology at the Durham Regional Cancer Center. He went to school at McMaster and then did hematology training at U of T. And we're very lucky to have him as our section lead for hematology at the Cancer Center here in Durham Region, and happy to hear what he has to talk about today with respect to managing hematological conditions. So with that, I'll turn it over to you, Dr. Naassan, and we'll have questions at the end. This is being recorded, and if you don't have an email address that gives us your full name for your certificate for participation, please put your full name in the chat so that we can make sure we make those out appropriately. But if your email address says kind of conveys who you are, we will figure it out and get those certificates off to you after this session. Turn it over to you, Dr. Naassan.
Thank you so much, Shannon. Do you guys all hear me? Perfect. My camera is not working, so it just kept giving way. But do you guys all see the presentation as well?
Yeah, that looks perfect.
Okay, perfect. Okay, so thank you so much, Shannon, for having me, and thank you all for making time today at lunch to go over some hematology issues that you face in primary care and your primary care practices. So again, I'm Anthony Naassan. I've been here at the Durham Regional Cancer Center for 12 years now, and I care for patients both with benign and malignant hematological disorders. With respect to disclosures, I don't have any that pertain to the current presentation. Now, the overview is quite basic. I want to make it as interactive as I can. It's hard in these video environments, webinar environments to do that, but I just want to touch upon common presentations of hematologic disorders, both benign and malignant, that relate to family medicine practice, and also try to touch upon when best and how to refer to hematology. Now, just a quick plug for who we are. So we serve at the DRCC very large, between DRCC, Peterborough, and Northumberland Hills Hospital. The hematologists serve a very large geographic area that's noted here, excluding Scarborough. The rest of it is served by the DRCC-based physicians, Dr. Shatner, Dr. Woods, myself, Dr. Koblovic, and Dr. Basantha Mohan, and Peterborough's served by Dr. Ismail Sharif. Dr. Basantha Mohan does go to Coburg once a week only to see outpatients in the clinic there on Tuesdays. Now, the referral to hematology occurs through the DRCC. So, we often get calls, how do we refer to hematology? Well, it's through the DRCC and the Cancer Center referral form. And we do have a triage system. So once your referrals are sent off our way, we do review them and determine the priority. Urgent and malignant consultations are seen within the 2-week time frame, ideally. However, if you have an emergent hematologic concern, we would suggest paging us and also sending the patient to the nearest emergency department to get that dealt with. Now, just a quick plug for OTN e-consults. So there exists OTN e-consultation service for hematologic disorders. So if you have any questions on blood work, or just a quick, you just want to run something quickly by a hematologist, there's always this feature that's available. So the OTN page is here, and basically you would click on this e-consult button, and you would look for the hematology group. I am part of that group, and I do answer quite a number of e-consults weekly and from across the province. So it's hematologists from across the province that serve to answer these consults, and we try to turn around those consult requests within the 7-day time frame, ideally. So let's start with a presentation of patient with high ferritin. Any questions, sorry, about who we are, consultation or referral process before I move forward? I can't see if anybody has their hand up, but I'm
No
assuming not.
hands.
No
No
hands.
hands right now.
Okay. So we'll start off with a case of a patient with an elevated ferritin. So it's a 60-year-old gentleman with a 3-month history of fatigue and joint pain, and he does drink 2 beers a day, does not smoke. He has a family history for type 2 diabetes. And on exam, there was very mild hepatomegaly and had some enlarged and tender knuckles. Blood work showed a normal fasting blood sugar, mildly elevated liver enzymes, ALT and AST, and he stopped drinking, and the AST and ALT remained elevated. The family doctor obtained hepatitis serology and a ferritin. The ferritin was elevated at 640, upper limit of normal for that lab was 300, and a transferrin saturation of 60%, and this came to me a few months ago. Now, just a quick touch on when to consider iron overload and hemochromatosis. So if you have a patient that's symptomatic, we call it, yeah, patients are symptomatic when they have features that would suggest possible iron overload. So some of those scenarios include unexplained liver disease with unexplained elevated abnormal serum iron markers, type 2 diabetes in the context of hepatomegaly, elevated liver enzymes, atypical heart disease, especially cardiomyopathies that are non-ischemic, as well as early onset sexual dysfunction and early onset arthropathies, again, cardiomyopathies that are non-ischemic, and male sexual dysfunction. There's a group of patients that don't have any symptoms on presentation that we should think about iron overload. These include patients that, you did routine blood work and you find their liver enzymes are a bit abnormal. On exam, they have very mild degree of hepatomegaly, or if they have abnormal serum iron markers on blood work, this could be a representation of hemochromatosis that's not symptomatic, hasn't presented yet in terms of patient symptoms. And patients who have first-degree relatives of confirmed hereditary hemochromatosis cases should also be considered as possibly having this disorder. Now, what is hemochromatosis? Well, it's a disorder of iron overload, and hereditary hemochromatosis is usually what we think about, the genetically passed on disorder that leads to iron overload. But there is also the existence of acquired iron overload. Patients, for example, that I care for that have myelodysplastic syndrome or acute leukemia are getting transfusions. When they get to 10, 15, 20 transfusions of red cells, they often develop features of iron overload. So that's another population we won't touch upon more today, but that does exist as well. Hereditary hemochromatosis, like we discussed, is a genetic defect, and it basically is a result of excess iron absorption from the gastrointestinal tract. And the symptoms of hemochromatosis are due to pathologic deposition of iron in body tissues, leading to iron overload in those tissues. Now, what we've all learned in medical school is the classic triad of cirrhosis, type 2 diabetes, and skin bronzing. Fortunately, we don't see that anymore, because if we did, it'd be too late. In this day and age, with family doctors screening, looking after patients in the community, we are catching this before these end organ features present themselves. So we're not going to see this as often anymore. And if we do, it's unfortunately that we caught this too late. We would never wait that long to treat patients. In terms of other non-specific signs and symptoms, well, it does run the gamut of, liver pathologies like we spoke about, hepatomegaly or abnormal liver enzymes, cardiomyopathies, erectile dysfunction, amenorrhea, diabetes, musculoskeletal complaints, and fatigue in general. It's important to recognize that a lot of these symptoms with respect to iron overload don't present until a little bit later in age. In males, usually younger. In females, at a later age due to menstrual periods. So something just to be on the lookout for in general. Now, how do we investigate for this? Well, transferrin saturation tends to be what we're looking for. Transferrin saturation over 50% indicates significant iron accumulation. We talk about ferritin levels, and the cutoffs do vary. The cutoffs that we would use typically are 300 for a male, 300 for a postmenopausal woman, or 200 for a premenopausal woman. Unfortunately, oftentimes Life Labs and other labs use other cutoffs that are not reflective of this. I saw one recently that was 160 as the upper limit of normal, and the referral came with a ferritin of just over that. I think it was 180 query iron overload, when that's not the case. So we have to recognize that some labs use different upper limit of normal. And these are, we would stick to the 300 for men or 300 for postmenopausal women. Liver biopsy can also be used in the context of elevated ferritin levels for diagnosis of iron overload. In terms of diagnostic testing, you're really talking about genetic testing, DNA testing for HFEG mutations, both the C282Y and H63D mutations. Important to remember that ferritin is an acute phase reactant, and it's also contained in hepatocytes. So any systemic inflammation or liver inflammation for whatever reason, alcoholism, can cause an elevated ferritin. So ferritin alone, an elevated ferritin alone, is not suggestive of iron overload. It would be a ferritin that's elevated in the context of an elevated iron saturation. So something to keep in mind when sending the referral over. Now, genetic testing, again, for hereditary hemochromatosis is used for the diagnosis, and genetic testing is warranted in appropriate clinical presentation, like we mentioned, an elevated transferrin saturation and ferritin. Liver biopsy that's suggestive of iron overload would lead us to go ahead with the DNA testing, as well as a first-degree relative of a known case, if that's brought to our attention. In terms of the genetic testing, again, we spoke about the HFEG mutation, and this is associated with hemochromatosis and accounts for 90% of cases. There are other genes and genetic mutations that can cause iron overload, and we won't touch upon these here. They're rarer for certain. The HFEG mutation, the C282Y mutation, occurs in Caucasians and Northern Europeans at a rate of 1 in 7 to 10, and the incidence of homozygous C282Y mutation is 1 in 2 to 400. The penetrance is low. It's actually quite variable. Remember, even if you have the mutation, it doesn't always mean that you have the disease, the iron overload. And you think about, for example, a woman with regular periods who's given birth to a number of children, who donates blood through Canadian Blood Services. That person will not have likely iron overload, at least not in her younger years. But as time goes on, we might start to see iron accumulation, the ferritin, the transferrin saturation starting to increase. The HFE gene is on chromosome number 6. Again, it's involved in iron hemostasis. It is normally limiting the amount of iron that's taken up by the gastrointestinal tract and regulates the amount of iron that's stored in different tissues. So if that's not working correctly, you're going to have an increase in iron absorption, as well as an increase in the amount of iron that ends up in tissues where you don't want them. There are 2 mutations that are common, the C282Y, which is the most common mutation leading to iron overload, and the H63D mutation, which is less likely to result in iron overload. The goal of management, in general, the goal is to detect patients before symptoms of iron overload. When we do identify iron overload with an elevated ferritin and transferrin saturation, phlebotomies are instituted, usually weekly or biweekly upfront, sometimes monthly. We check ferritin every 4 to 8 phlebotomies every few months. And usually we aim for a ferritin of less than 100. If that ferritin reaches 100 and below, target, some people are a little bit stricter in terms of target, down to 50. Again, we want to balance that with the risk of resulting in iron deficiency and iron deficiency anemia. So we don't want to go too far with the phlebotomies. Usually patients require phlebotomy every 3 to 6 months. We have some basic dietary recommendations asking patients to stay away from iron supplements. Vitamin C can increase iron absorption, so stay away from vitamin C. Stay away from iron foods that contain high iron, like liver, for example. But otherwise, everything else is in moderation. Consider a hematology or gastroenterology referral if you have a confirmed case and to guide treatment and monitoring. So take-home message for an elevated ferritin is that patients with elevated ferritin and normal iron saturation, that doesn't suggest iron overload. So an elevated ferritin alone needs to be investigated further. There likely is systemic inflammation or liver disease that's driving that ferritin. If the transferred saturation is 50% in the context of an elevated ferritin, then that suggests a picture of hereditary hemochromatosis, and this should be investigated further with DNA testing. And the management is quite simple, being phlebotomy of blood donations. So that's elevated ferritin. Do I have any questions? I'm just going to pause there for a minute.
There's a question in the chat, Dr. Naassan. It says, it may seem like a silly question, but is any of the blood from a phlebotomy able to be donated?
Yes, that's often asked. And no, it's not, unfortunately. In the cancer center, we don't have the resources, means to do that. So what happens most often is that the patients, once they're brought down to a ferritin of under 100, and we're happy with that, and they've tolerated everything, we send them to Canadian Blood Services. Canadian Blood Services can accept blood every 8 weeks on average. So that's where most patients end up for their maintenance or long-term management. And that's the area, those folks can collect the blood under the conditions needed for blood donations. Yeah. Good question.
Another question here says, do you think GPs should be doing the genetic testing or leave that to hematology?
No, GPs often do. So we do get referrals. Oftentimes, in the correct clinical context, it is appropriate for the family doctor to obtain the test. Again, the elevated ferritin and elevated iron saturation is likely a picture of hereditary hemochromatosis, especially if there's a family history that comes along with that. There's absolutely nothing wrong with the family doctor ordering it. The management bet might need our assistance because you won't be able to arrange for blood donations to be done in a manner that can bring that ferritin down. Like I say, once the ferritin's brought down, then they could be discharged back to the family doctor and managed through Canadian Blood Services. But in the initial period, the management might be we may be required to help out with that management. Also, gastroenterology. At our center, it's the hematologist. Some centers, not in Arlin, but in other areas, the gastroenterologists do manage that.
And a follow-up question then is, what exactly should be ordered for that hereditary testing?
So HFE gene testing. So Life Labs and Gamma Dynacare on their website do have the genetic testing form available. So you would just search HFE gene or hemochromatosis gene testing through those labs.
And I'll follow up with my own question. Do you know if that's OHIP covered or is there a cost to the patient?
No, there was no cost for that.
Great. Thanks.
All right. So moving along. So this is another case that I got to see. And we, just to highlight a little bit about what we see on our end when we get these referrals. So it's a 27-year-old with anemia, and they sent a copy of their blood work that showed a total white cell count of 5.6, hemoglobin of 91, MCV of 66, platelet count of 338. And oftentimes, unfortunately, less so now with EMR systems, but sometimes all we get is what's on the right side there. Chronic anemia, no cause, no evidence of GI. There's really not much else there. And we would, we don't expect people to be hematologists out there in the community, but it'd be nice, I think, to get a little bit more information than that. We're often not going to send this back to the family doctor because the blood work is representative of an issue that needs to be dealt with. But it would be nice to get a little bit more information. This is from a colleague of mine in Manitoba and Winnipeg that had a similar presentation to make. So I didn't want to, put any of the family doctors in our area out to dry. So this is not from here, but we do see these referrals that come in. So, basically 6, 7 words and some blood work attached. It would be nice to get a little bit more information, a little bit more history to go with that. In any case, moving forward, so we have a patient with microcytic anemia. She's 27 years old. What investigations would be most appropriate at this time? So things to think about are iron deficiency. We talk about ferritin and iron, serum iron, TIBC, iron saturation. Also, we also forget often, and we do too in hematology, we forget about the reticulocyte count sometimes. The reticulocyte count can provide us with some valuable information. A basic hemolytic workup, an LDH, a haptoglobin, bilirubin. And depending on patient's background, so if they're from anywhere around the equator, I say, so Mediterranean, Southeast Asia, the Caribbean, hemoglobin electrophoresis in the absence of iron deficiency would go a long way as well, adding to the case that this may be a picture of thalassemia or thalassemia trait. So the undifferentiated anemia, remember the anemia is very common, and anemia is often more important as an objective indicator of illness than a problem truly for the patient. So we get these milder anemia. So we saw 99 here or 91 here, but we get in the mid 120s. Well, that could indicate, let's say in a male 120, that could indicate there is a problem and something else going on rather than a problem in and of itself. Every case of anemia warrants some thought, warrants investigations, and really, everybody should try to come up with what may be causing the anemia. Oftentimes, generalists, family doctors, internists can come up with some thoughts, but it's very important not to just leave an undifferentiated anemia alone, especially new onset undifferentiated anemia alone, because it could represent something systemic that's being missed. Three practical rules to think about when dealing with an undifferentiated anemia. One, the first is probably look at prior CBC results. So, if the person's been anemic for the last 20 years, well, that's very different than, a healthy 35-year-old male coming in with a hemoglobin of 90, whereas 6 months ago it was normal. Very important to get a sense of if this is new or old. Also, if the abnormality is minor, it may warrant repeating that test to see whether or not it was due to some transient phenomenon. And when formulating an investigation plan and establishing a diagnosis, always take into account the clinical information you have. That's very, very, very important, and it'll go a long way. I had a lady yesterday that, was referred to us with anemia, and we looked, and she had an MI back in May of 2022, and that lady was started on Plavix and aspirin in May of 2022. In April of 2022, blood work was normal, her CBC was normal. She became anemic soon thereafter. Well, it was probably the antiplatelet agents. So the clinical context and the story go a very, very, very long way to helping come up with a possible cause for anemia. Very, very important to look at the whole patient from beginning to end. Now, this is a very, very complex yet simple algorithm that was passed on to me by one of my colleagues out in Winnipeg, Dr. Houston. You could break down, and I think it is fair to break down anemia into the MCV. So whether it's microcytic, normocytic, and macrocytic, like we learned back in medical school, just go down the macrocytic stem for a second. You think of things like B12 deficiency. You think of alcohol, certain medications like methotrexate, hydroxyurea, liver disease, and bone marrow disorders can all be contributing factors of macrocytic anemia. On the microcytic side, oftentimes we think of iron deficiency, but also should think of things like thalassemia and anemia of chronic disease. The normocytic anemias are the more complex ones, but you can still break them down a little bit into either high reticulocyte count, hyperproliferative anemias. So you're producing tons of red cells, but you're still anemic. And that's probably because you're either losing it through bleeding or you're breaking down your red blood cells. So LDH, bilirubin, haptoglobin go a long way in coming up with a diagnosis of hemolysis. If you're not making many reticulocytes, you're probably dealing with something That's not really driving the bone marrow. You become anemic because your EPO levels are low in the context of chronic kidney disease. So look at a creatinine there. Certain medications, alcohol as well, can affect the bone marrow. And inflammation, so an ESR and CRP. You can have both an iron deficiency anemia and B12 deficiency anemia, causing the MCV to appear normal. Again, things like thyroid disorders, androgen deficiency, either acquired through age or because of medications like the drugs they give patients with prostate cancer can cause a hypoandrogen state and an anemia as a consequence. And then the classic bone marrow disorders like myeloma, myelodysplastic syndrome, other marrow infiltrative disorders. It's a very complex diagram, but if we have a a rubric to break it down in our minds, it's actually quite simple. Just to put a plug here at the top right is patients that present with multiple cytopenias. This is different than patients with a simple anemia. I just want everybody to remember that. If anytime you see multiple cytopenias, your eye should really go to the smear. And if there are abnormal forms, fragments, just to say it's blasts, nucleated red cells, any comments of dysplasia, that should be seen by a hematologist on an urgent or emergent basis. Should be any waiting around. It should be a phone call at a minimum to a hematologist. This could be something like acute leukemia or TTP that needs to be dealt with on an urgent basis. Back to our case. So this repeat CBC showed a hemoglobin down a little bit to 72 and her MCV was 63, but her ferritin was only 2. So this is a case of iron deficiency anemia, which again is typically associated, as we've discussed, with microcytosis. And the ferritin is one of the best tests to identify iron deficiency. I think I'm echoing here. Sorry. Does everybody still hear me, Shannon?
Yeah, sorry, someone came off mute, but I've muted them. We're all
Oh, okay, no problem. Is there a question though? No questions?
There's one question in the
Sure.
in the chat. It just says, I
Please.
wonder if you get a lot of emerge referrals for unattached patients that just aren't fully worked up.
Fortunately, no. Not for plain old anemia. Fortunately, not as many. We get a lot of those for DVT and PE. Yeah, so a couple. I can't think of. It's not a huge number. That's for sure. All right. So anemia again. Ferritin is iron deficiency anemia. Ferritin is your best test to identify. Again, the drawback here, same as we talked about with the iron overload conditions, is that ferritin is an acute phase reactant. So it could be artificially elevated and could be misrepresentative of the actual iron stores the person has. So just to go through it briefly here, iron deficiency again is associated, iron deficiency anemia, with anemia, a low MCV, a low iron saturation, and a low ferritin. Anemia of chronic inflammation, and that's something that sometimes is confused. You'll get your anemia, your MCV could be this normal or the same. Your iron saturation is likely not always very low. It tends to be 20%ish, but your ferritin is elevated. So something to think about is looking both at the transferrin saturation as well as the ferritin. Now this is another diagram here that, again, from my colleagues out in Manitoba, they broke it down into low ferritins, very low ferritin, so ferritin under 30, which is diagnostic of iron deficiency in most cases, and ferritins over 100, where iron deficiency is less likely. It's this wishy-washy ferritins between 30 and 100 where you might need a little bit more in terms of testing, and there's your iron saturation, where your iron saturation comes in handy. If your ferritin is so and your iron saturation is low, it's probably a picture of iron deficiency. If your ferritin is not nor here nor there and your iron saturation is normal or high, it's probably not iron deficiency. So, we talk about some labs will look at the lower limit, will mention the lower limit of normal of a ferritin being 15. But studies have shown that ferritins of under 30 actually have a good sensitivity and maintain the specificity of iron deficiency. So, bringing up that lower limit of normal of ferritin from 15 to 30 might help you catch some iron deficiencies that may have otherwise been missed. And again, like we mentioned, inflammation can cause the ferritin to increase, and therefore you could really miss a section or segment of patients with iron deficiency if they have concomitant inflammation. Again, ferritin could be elevated in inflammation, but also in cases of liver disease. So something to think about. So important to remember that iron deficiency anemia is not a final diagnosis. By no stretch of the imagination should it ever be a final diagnosis. It's really a symptom of something else going on. So the first thing you need to do is figure out why the person is iron deficient. That's the crucial key. And we think about conditions associated with iron deficiency as being either due to decreased iron availability. So I've caught, I would say, a dozen patients with celiac disease. Inflammatory diseases, right, can prevent the use or the uptake of iron. Chronic kidney disease can also play a role. The more concerning conditions are those that are associated with blood loss, occult blood loss. And I've caught, unfortunately, way too many colon cancers, esophageal malignancies, malignant gastric ulcers in this way. So if you're losing blood chronically, we're talking about a teaspoon, maybe not even a day, right, of blood over months or years, that will produce a degree of iron deficiency that will manifest itself on the CBC. Also, other conditions that are associated with iron deficiency are pregnancy and breastfeeding. And then the one that patients or people and patients often forget about is blood donations. Had patients that were donating blood for years and years, and they were vegan, for example, and then all of a sudden they start to become iron deficient, and they become anemic, and Canadian Blood Services rejects them, and they wonder why. Well, it's because they're clearly iron deficient due to iatrogenic reasons. So iron loss in pregnancy and breastfeeding on average is 1,000 milligrams for the pregnancy. Remember, with our diet, we're taking in at most maybe 1 to 3 milligrams on a daily basis. Menstrual blood loss is 1 milligram per day. Iron loss in hemodialysis is quite significant at 2 grams per year because of the filters and the tubing and everything else that's involved. So when do we treat iron deficiency? Well, if you come up with iron deficiency or iron deficiency anemia, you should treat them. And the first go-to is your oral iron supplements. Intravenous iron is available. It's not easily accessible. It's costly and very time consuming, but it does exist. And we try to avoid blood transfusions in iron deficiency anemia unless there's real hemodynamic instability. And just to touch on the iron, the intravenous iron. So there are a number of products now that are available. There's Venofer and more recently Monofer. The issue again is administration. Unfortunately, the way that our center at the Durham Regional Cancer Center is funded and structured is there's really no room for paying for outside non-malignant patients. However, other centers might be structured differently, so I don't want to comment on them. Oftentimes, we can maybe squeeze them in for a dose of iron, but if they need ongoing intravenous iron, they have to be referred to either Bayshore or Innomar Clinic, and a lot of that cost would be out of pocket for the patient, unfortunately. So it is a much more difficult avenue, but it is possible. In some conditions, it might be necessary. So we talk about oral iron. Oral iron preparations. Ferrous sulfate is, one of my first go-tos to start off. If patients have already GI upsets and have issues, proferrin with less elemental iron might be my go-to in that context. There is always talk about things like Ferromax or the liquid iron, the ferrous sulfate elixir, as options that increase GI tolerability. And anecdotally, I would say, yeah, I believe it. There are some pregnant women who have issues with absorption and with nausea and with other GI concerns that actually did better with Ferromax in my hands than with ferrous sulfate. But again, there isn't really any studies to support that particular claim, unfortunately. So which iron is most efficacious? Well, the one with the most iron in it. Really, you're looking at quite basic in terms of evidence. So more iron in the capsule, more iron that can get through, the more iron that'll get absorbed. Which one's best tolerated? Well, the one with least iron in it. There's minimal iron, it'll cause least GI toxicity. Unfortunately, there's no evidence that one preparation is more effective or has fewer side effects than the other. And this was published in a journal article a number of years ago. So take home message, anemia is an indicator of illness rather than a diagnosis in and of itself. Undifferentiated anemia should be investigated fully to determine a cause and we should break down anemia based on MCV and reticulocyte count to try to provide the family doctor, nurse practitioners with a rubric which to base further investigations testing. Microcytic anemia, you should always check the ferritin as a good starting point. Other anemias, check the creatinine, check liver enzymes, LDH, bilirubin. Forgot to mention it here, but ESR and CRP, given the possibility of inflammatory anemias. If you have any patient with a pancytopenia, blasts, immature white cells, any hemolysis, or if you're unsure, please reach out to us. We're more than happy to help. Any questions about the undifferentiated anemias before we move forward?
So 2 questions in the chat right now, Dr. Naassan. So one says, these algorithms are great. Are we able to get a copy of the slides?
Shannon, it's up to you.
Oh yeah, no, I'm fine with that. If you're okay with your intellectual property being shared. Great. And then when a patient has normocytic anemia that you suspect is on the basis of chronic kidney disease or an autoimmune condition, how extensive should the investigation be? Should these patients generally see a hematologist?
So in terms of chronic kidney disease, that's best served by the nephrologist. So I'd say, one number to always think about is an EGFR of about 30 or below will about 90% of patients are anemic. So 30 or below, the majority of patients are going to be anemic. But if you have less of a degree of anemia, less of a degree of kidney dysfunction, you'd have to look for other causes. So we're not talking about the creatinines of 110, 105. We're talking about creatinines in the 140, 50, 60, 70 range and up. So, something like that, I would say refer to a nephrologist for sure. Sometimes a nephrologist will refer them up to us saying, the degree of anemia is out of keeping the degree of renal insufficiency. And that we see a lot of. With respect to inflammation, so if you have an elevated ESR and CRP and they're anemic, well, you got your cause of anemia right there. And probably the patient would be best served by a rheumatologist because there might be something underlying that. PMR, right? Polymyositis. There are a lot of conditions that might be difficult to elucidate. Other thing to always think about is underlying cancers, undiagnosed cancers will oftentimes present with elevated CRP, ESR, anemia. So something to also think about. We don't want to leave those without more investigation for sure. Anything else, Shannon?
No more questions at this time. No.
All right. So another common complaint and common referral is lymphadenopathy. So lymphadenopathy, would present through the family doctor and often be referred to us. So just want to walk you through a patient, Mr. PD, developed adenopathy about 2 months. Let's say 4 months ago, he visited the family doctor 2 months after the initial concern. And he had what sounded to be a viral infection about a month before the lumps came up on his neck, the right side of the neck. He then started to experience weight loss, fatigue. And I think it was his wife that said, you know what, you got to go to the family doctor. Didn't go to the family doctor until he developed pain in the belly and started to worry. So I'm sure family doctors have seen this more than a few times. So Mr. PD on exam had a, quite large, patients often will believe this for a long time, quite large mass sitting just under his right ear there, high cervical chain, and also had a mass palpable in the axilla. His CBC was normal. His LDH was slightly elevated. And the CT scan showed a large mass in the neck, chest, large masses in the neck, chest, largest in the abdomen, measured 10 or 11 centimeters. I can't remember the details, but this is not an uncommon presentation. So when we think about lymphadenopathy, what do we think of? Well, we could think of in a localized environment. So if it was just a lump in the submandibular area after a viral infection, think of infections. Inflammation, malignancies, can also cause these focal localized lesions. So not to be just left alone would require follow-up. So I, for example, saw somebody with a tongue cancer who developed a cervical chain node. It came to us as, query, new lump, could be lymphoma. We biopsied it, and unfortunately it was squamous cell carcinoma. So even the localized nodes could be malignant, something to think about. Generalized adenopathy, we could see in unusual infections, rare infections, so EBV, HIV, mycobacterial infections. We see an inflammation. We see patients with sarcoid, certain medications, and lymphoma, obviously, as well as a possible etiology. The history is key as well, the timing, how long this has been going on for, if it just appeared all of a sudden, if it was persistent, if there are associated fevers, night sweats, weight loss, and the use of any medications. Now, in terms of when you examine these, you want to get a sense of the size. Abnormal nodes are more than a centimeter typically. They tend to be rubbery and not painful in malignant state. The idea is that you want to get a sense of the consistency and whether or not they're fixed, as well as, again, tender or not tender. The key to all this is, again, imaging. That will be your next logical test. If there's a persistent large node, a biopsy is needed. Ideally, an open biopsy will give us the most information going forward, but oftentimes we will have to do with a core needle biopsy. FNAs aren't really to be used for diagnosis of lymphoma, but can exclude metastatic carcinoma. So lymphoma cannot be diagnosed with an FNA. Now, what oftentimes patients say is, or even family doctors say, what do these things look like? Well, on the top left corner there is a CT scan of the gentleman, and you can see that there's a large mass that's encasing the aorta and pushing the spleen to the side. So that's basically a representation of retroperitoneal adenopathy. And this is a picture on the right bottom corner of diffuse large B-cell lymphoma. And basically what you have is these abnormal lymphocytes that have become malignant and have caused complete effacement or destruction of the follicles and germinal centers in the lymph node. They're kept within the lymph node. You could see that they're encapsulated within the lymph node. So they're not climbing out of the lymph node. They're not like metastatic cancers would break through layers. This is kept within the lymph node structure, but replaced and growing within that lymph node. So when, things to think about with lymphoma, there is a slightly higher preponderance, men versus women, 2.3 versus 2%. There are a few risk factors that increase the risk: primary immune disorders, so CVID, autoimmune diseases, organ transplantation, HIV. We talk about drugs that modulate the immune system, so the anti-TNF agents, for example, that are used in rheumatologic disorders. Those are all risk factors for lymphoma. Most patients will come to the family doctor with a new lump or bump. That's how they're going to present. That's how they're going to come to us eventually through you. Most cases, present again with lymphadenopathy with a positive predictive value of 18% in patients over the age of 40. So not all lymphadenopathy is lymphoma. B symptoms are seen with the aggressive lymphomas in patients with high disease burden. So we're talking about fevers, chills, sweats, weight loss. These constitutional symptoms can increase the positive predictive value of the adenopathy. So you have a patient with lymphadenopathy and these constitutional symptoms with abnormal cytopenias or with a high white cell count. This is all suggestive of a possible picture of lymphoma. Unfortunately, there's no screening test. There's no screening program like breast or colon cancer screening. It's unfortunately the rate in the population is not high enough for this, and there are no very well established population screening investigations or maneuvers that exist at this time. Now, what red flags exist? So when should you have a high suspicion of lymphoma? Again, we talk about lymphadenopathy in high-risk patients. Again, high-risk patients, the ones that are immune deficient. HIV patients who've had lymphoma in the past can have recurrences. It's something to think about. Lymphadenopathy and abnormal blood work, including anemias, thrombocytopenia, or pancytopenia, should be suspected of having possible active lymphoma. Patients with widespread adenopathy and splenomegaly, patients with a mediastinal mass, lymph nodes that rapidly grow, again, lymph nodes and B symptoms, and patients who are symptomatic from abnormal lymph nodes, so lymph nodes that are pressing on the heart or lungs, causing abdominal pain. Now, when we talk of lymphoma, we're talking about it as one entity. However, very important to recognize that it's actually multiple entities. It's not one. We break it down in the lay public as Hodgkin's and non-Hodgkin's. The Hodgkin's lymphoma are the red or red toned lymphomas in this part of the pie, but the majority of lymphomas are actually non-Hodgkin's lymphoma. And the largest non-Hodgkin's lymphoma that we see, the prototypical aggressive non-Hodgkin's lymphoma is diffuse large B-cell lymphoma, which makes up just under half. And the prototypical low-grade lymphoma is the follicular lymphoma, which makes up about a quarter of lymphoma presentations. So just a quick summary and recap of non-Hodgkin's lymphoma, just to give everybody a flavor of what we see and how we treat them. Patients are either have an aggressive lymphoma, prototypical diffuse large B-cell lymphoma, Burkitt's is very aggressive, or indolent, we talk about follicular lymphoma, marginal zone lymphoma. Now, the principle of treatment for indolent or low-grade lymphomas, in general, we say they are not curable by standard chemotherapy, but they are treatable, and there is a possibility for functional remission and functional cure. So they may achieve remission for years, for dozens of years. You know, if they're 80 and they're in remission for 20 years, well, that's great. And that's, you know, as close to cure as we're going to get, but not curable in the traditional sense, where we can guarantee that it won't happen, it won't recur again. So none of the curves, when we look at progression-free survival, plateau anywhere. That's basically what we're saying. There is always a risk of relapse. Watch and wait strategies up front are often utilized in patients who are not symptomatic. So patients could have lumps and bumps, feel well, no symptoms associated with them. We don't do anything except follow them very, very closely. And this is because there's no evidence that earlier treatment makes any difference with outcomes, either from a relapse perspective or overall survival perspective. Aggressive lymphomas, again, the prototypical diffuse large B-cell lymphoma is curable. So there is a plateau that's achieved in that PFS curve. The potentially curable a regimen of R-CHOP is used, but now we're, you know, depending on the aggressive lymphoma, we might change that around. But in general, it's R-CHOP that you'll hear being used, and treatment should be initiated as urgently as possible. Patients are usually symptomatic with these aggressive lymphomas, and realistically, they might suffer a life-threatening complication or die within weeks to months if not offered treatment. So these are patients that we see quickly, we start on treatment quickly, and hopefully are cured. So take-home message for lymphadenopathy. Again, patients could present with nonspecific symptoms. We got to think of not only the lumps and bumps, but fevers, chills, night sweats, weight loss, abnormalities in their blood work, including CBC abnormalities, and always follow up with CT scan preferably and get a biopsy. FNAs, we just need to remember, cannot diagnose lymphoma. So good at excluding metastatic carcinomas, but not great at diagnosing lymphoma. Now, any questions at this point?
We do have one here. It says, with regards to lymphadenopathy, what's the significance of cortical thickening when found on ultrasound? If found, should it be a trigger for a specific workup?
If the lymph node is enlarged, or it all depends. So in the context of a normal sized lymph node, it could be an inflammatory change. So maybe repeat the imaging would be the safest way to proceed.
And another question just came in. For the CT, are you starting with just at the notable node, or should we do body?
You could start with the node or the area that's of concern, because it's probably the quickest way to get it. If there are no symptoms anywhere else, I probably wouldn't get CT until we can order that. So it's not wrong to say you'll only get the CT of that area to get a better idea of what you're dealing with, and then order tests as appropriate after that's resulted. Okay. Are we good?
Yep, so far so good.
All
Oh,
right.
wait, one more came in.
Yeah.
Is an ultrasound a good starting point versus the CT?
Yes, ultrasound is usually going to be your starting point. However, if it is persistent, I would say CTs. Then you're gonna move to CT.
Thank you.
All right. So just a quick case. This is a quick case. It touches on the anemia, a bit of the anemia case that we spoke on about. So it's a 75-year-old. I saw him in, I think it's no, maybe last month, but he presented in September with fatigue to the family doctor. It's from Sunderland. He had anemia and thrombocytopenia. He was asked to go to the emergency department. He was transfused and sent home, unfortunately. Then I think he was told to follow up with a family doctor. That didn't happen. His fatigue worsened. He developed epistaxis, gum bleeding. He couldn't walk up the stairs at home. He came through the emergency department, and basically at that point was referred to hematology. Unfortunately, he presented with pancytopenia. So he did have a degree of neutropenia, close to zero. He had a platelet count, I think it was 107, and his hemoglobin was 106. I think this is just a case that I wanted to use to highlight the importance of pancytopenia on presentation. This should be, the first thing we should think about is looking at the smear. And I can't emphasize this enough, because that gentleman did have actually some dysplasia and had, I think it was a blast. It wasn't like a huge number of blasts, but it still was mentioned on that in the September, and I saw him in October, November. So he wasn't unfortunately forwarded to us as urgently as he should have. Fortunately, he's still with us and he's okay. But just to highlight the importance of any blast, the mention of it should really trigger a quick referral to hematology. There were, in the case of, I just want to highlight here. So you're looking for fragments to exclude TTP. You're looking for blasts. Again, that could indicate an underlying bone marrow disorder, nucleated red cells, dysplasia, immature white blood cells. All of that any of those things should really elicit a referral to a hematologist. A phone call, we are always happy to help out. So we talk about pancytopenia, we talk about 2 or 3 lines being involved. So either your red cells, your platelets, or your granulocyte lineage, especially, the ANC in particular is what we're worried about. First thing to do, again, looking at the smear, you want to rule out microangiopathic hemolysis. So you're looking for fragments. These pancytopenias usually, not always, but usually can indicate an underlying bone marrow problem, whether be it bone marrow suppression from a medication, from infection. We think about parvovirus B19 causing it. Certain drugs, chemotherapy can cause pancytopenias, anorexia, malnutrition. But in our realm, in the hematologist realm, we're thinking of things like myelodysplasia, acute leukemia, myelofibrosis, lymphomas that could have infiltrated the bone marrow, and rarely Gaucher's disease. So, pancytopenia should really trigger, I think, for sure, a referral. Pancytopenia and any abnormality on the smear should be treated a little bit more urgently. And when we see those on triage, we do see them much more quickly. Again, in the mild pancytopenia, that's a little bit of a different beast. Without any abnormalities on the smear, you may want to repeat the blood work for starters. If the MCV is elevated, you want to think about things like B12 deficiency. You want to think about things like liver disease. You want to just scope out other possibilities. It's not always going to be leukemia. It's not always going to be the worst case scenario. So if it's mild, you have a little bit of room to maneuver, to look for other causes. And you should take time to look for those causes. Maybe get an abdominal ultrasound looking for occult liver disease that might have been missed. Urgent referral, I would say if your ANC is less than 1, hemoglobin is less than 70, and or platelets are less than 50, you would send them our way, order more blood work, repeat the blood work, keep a close eye on them. In a case where the ANC is less than 0.5, platelets less than 20, that should elicit some more urgency and probably a phone call to us at a minimum, along with a referral. And in the case of schistocytes or fragments, blasts, that straight, that phone call and likely a referral to the emergency department as well. So this just highlights what we spoke about. I'm not going to spend much time. Again, pancytopenia, if you have the leisure of time, if you have the time, if it's not a major severe pancytopenia without any abnormalities on the smear, you have time to order things like repeating the CBC, getting an INR, looking at the B12, looking at liver disease, looking at other possible factors. I just want to go through here quickly. We talk about acute leukemia. Again, symptoms are very, very non-specific. So, fatigue, recurrent infections, bleeding, headaches, all of that in the context of severe pancytopenia, again, would elicit further investigations. I don't want to spend too much time on this. Just a quick plug for acute leukemia is not what it was, years ago. There's been a huge amount of improvement in the degree of, in the treatments and in survival. So it's not the leukemia of the 1970s where 95% of patients diagnosed would pass away from their disease. We're looking at a condition where probably 30 or 35% of patients are now surviving 5 years plus after their diagnosis with new treatments that are available. Even elderly patients have new treatment options that are available to us. So it's not the death sentence that unfortunately has existed for the last number of years. So there are new treatments that are available for the management of acute leukemia. So pancytopenia, need to know, again, should be referred to hematology in general. Include the laboratory, all laboratory values, history, physical exam findings, medications, and all the blood work and all the workup you've done to date. And the presence of severe cytopenias in the presence, again, of blasts, hemolysis, or fragments should be managed on an emergent basis. Thank you so much for joining us today. Thank you, Shannon, for organizing this.
Oh, this was a fantastic talk, Dr. Naassan. Thank you so much for putting that together. Very informative, and I'm sure everybody learned a lot. And we greatly appreciate your time and coming to speak with us today.
You're very, very welcome. Thank you, Shannon.